Join Nataliya Mar, MD, as she breaks down the most important genitourinary cancer updates at MOASC. Enfortumab vedotin plus pembrolizumab reduced the risk of death by 53% in advanced bladder cancer. In metastatic hormone-sensitive prostate cancer, adding a PARP inhibitor to next-generation hormonal therapy improved radiographic progression-free survival by over 30%. Long-term follow-up of IO plus TKI combinations in kidney cancer now shows median overall survival exceeding 4 years in some regimens. PSMA-targeted radioligand therapy continues to demonstrate significant overall survival gains in metastatic castration-resistant prostate cancer. Dual immunotherapy and antibody-drug conjugate strategies are delivering response rates above 50 to 60% in selected GU populations. In 3, 2, 1. How has the Talapro-3 trial changed your approach to treating patients with HRR-altered metastatic castration-sensitive prostate cancer?
So the Talapro-3 study looked at the use of Talazoparib, which is a PARP inhibitor, earlier in the prostate cancer continuum. And it is a phase 3 randomized study that was positive and met its primary endpoints. I think that this therapy will likely be FDA approved soon, and the data is compelling, and I think that once the FDA approval is in place, this will be adopted into clinical practice.
What's your opinion?
Just say yes.
She mentioned it during her presentation.
What factors help you decide whether to recommend adjuvant pembrolizumab plus belzutifan after nephrectomy for high-risk clear cell kidney cancer?
Adjuvant belzutifan plus pembrolizumab is now an FDA-approved treatment option for patients who have high risk of recurrence post-nephrectomy. The point that I was making during my presentation is that the trial has met its primary endpoint. It was a positive study. And the combination of belzutifan plus pembrolizumab did improve various endpoints over pembrolizumab alone. However, there is a trade-off with increased toxicity by adding belzutifan to pembrolizumab. So in the clinical practice scenario, it is a good option to use. But of course, the decision should be individualized based on patient characteristics and their pathology characteristics from nephrectomy. So I do use it for some of my patients, probably with the more aggressive features of their renal cell carcinoma. But you always have to be mindful of exposing the patient to extra side effects.
I agree with my colleague for the most part.
How do you sequence belzutifan plus lenvatinib versus cabozantinib for patients with advanced kidney cancer after prior immunotherapy?
The combination of belzutifan and lenvatinib is not yet FDA approved, so it is not on the market yet. However, I think this study is very thought-provoking because the combination of lenvatinib and belzutifan showed improved outcomes compared to cabozantinib alone in pre-treated patients with clear cell RCC. We will see how the overall survival will play out with longer follow-up. But I think it's definitely an interesting and thought-provoking study that we may end up using if the FDA approval comes in.
I still agree with my colleague.
How has the Keynote B15 data influenced your neoadjuvant and adjuvant treatment choices for muscle-invasive bladder cancer?
So the Keynote B16 data has led to an FDA approval of EV plus Pembro in patients with muscle-invasive bladder cancer who are cisplatin eligible. This is the new standard of care to use in this patient population. So it should be used routinely if you have a patient like that.
I still agree with her.
Why is early molecular testing becoming more important across these genitourinary cancers?
As more drugs are being developed in the genitourinary space, we are identifying mutations that we can target with these drugs. So, for example, in the prostate cancer space, I presented data on the Talazoparib trial that uses a class of drugs called PARP inhibitors to target tumors with certain mutations, like, for example, BRCA1 and 2 and others. And if we do not do the molecular testing to find these mutations, we won't be able to use the PARP inhibitors. So doing molecular testing early is very important because it provides us with extra treatment options for our patients. And also tissue ages as time goes on. So if you do not test early, then you might need to rebiopsy in order to obtain this test results later in the disease course. So I do genomic testing routinely for my patients with advanced or metastatic genitourinary cancers.
If you like this video, take a look at the web post companion on oncologytube.com, which includes more detailed information. Thank you for watching.